Hello everyone, and thank you for joining us for today's informative webinar. I would like to introduce Pam. So Pam O'Donoghue is our Macmillan Liver Cancer Specialist Nurse who recently joined our helpline team. Pam will be sharing some insightful information about liver cancer risks, diagnosis and support. Many thanks, Pam.
Thanks, Becky. Good evening, everybody. So for the next 20 minutes, I'm going to be chatting about the risks and causes of hepatocellular carcinoma and how important surveillance is in terms of early detection, diagnosis, and briefly touching on some treatments. I will also chat about where you can find support if you've been diagnosed with liver cancer as well. So in terms of just a little bit of background about HCC, about 6,200 people are diagnosed with liver cancer each year. Worryingly, the incidence of HCC has increased by 50% over the past decade, and this is expected to continue to rise. The existing evidence suggests that only around 20% of HCCs are currently diagnosed at an early stage. And this, of course, is quite worrying. Another type of primary liver cancer, bile duct cancer, also known as cholangiocarcinoma, which is rare. About 1,000 new cases every year are diagnosed in the UK. This may actually be a lot higher, but it's very difficult to capture this cancer because it sometimes is coded in a very similar way to primary liver cancer or other liver tumours, actually. So HCC is the third most common cancer worldwide, and it's the second most common cause of cancer mortality. The biggest risk factor for HCC is pre-existing liver disease, with liver cirrhosis being present in about 80 to 90% of people with HCC. In the Far East and Africa, hepatitis B and hepatitis C are the major reasons, and in the UK, alcohol-related liver disease from rising levels of alcohol consumption, fatty liver disease, previously called NAFLD and now called MASLD, which stands for metabolic dysfunction associated steatotic liver disease. Quite a mouthful, but I'll explain in a moment a little bit more about that. It's basically people who have increased body weight, obesity, diabetes, high blood pressure, high cholesterol, and this can cause fatty liver disease. And hepatitis C is also one of the major causes in the UK. So very, very worryingly, primary liver cancer is usually a late development in cirrhosis from these causes, as we've just mentioned. But the number of patients being reported in whom the tumour is developing in fatty liver disease alone, in the absence of any significant scarring of the liver, is increasing, and this is worrying. In terms of assessing your risk, I'm very, very pleased to say that the British Liver Trust now have launched their new liver cancer risk checker on the Liver Cancer UK website. It's available in the main menu of the LC UK website. It's designed to raise awareness of liver cancer risk factors, helping individuals assess their own risk, and it offers information and support for those who may be at higher risk. It's completely anonymous. It's quite easy to use. You'll be asked a couple of questions, and then you'll be given information and what next advice based on your combination of answers. It just takes a couple of minutes, and what it's really good at doing is identifying any risk factors that you might have, which then helps you to open up conversation with your GP in terms of getting more information about how you might remove or reduce those risk factors. The other sort of big development in terms of early detection is that we now finally have some clear surveillance guidelines which have been published this summer, and the British Liver Trust have been heavily involved with developing these much needed guidelines with NHS England. liver cirrhosis has never had a formal surveillance program in the UK. It's been quite hit and miss, and there's been a huge variation around the country about regarding who's managed to get onto a program and who's not. And we now have all the big associations in the UK who are interested in the study of liver and liver imaging, and the Liver Nurses Association, etc. They've all come together and helped to publish these guidelines to give direction to liver units and even to smaller DGH hospitals as to who should be surveilled. So this is a busy slide, but I just wanted to sort of demonstrate how comprehensive these guidelines are. They've thought of everybody really with any liver disease or risk of liver disease. So it includes patients with a Child-Pugh stage A. And for those of you who are not familiar with the Child-Pugh score, it's a tool used to assess how well your liver is functioning. Generally speaking, if you're an A, your liver is functioning quite well, and if you're a B, less well, and if you're a C, not so well at all, actually. So basically, if you've got liver cirrhosis, but even if your liver is functioning quite well, but you have cirrhosis, you should still be surveilled, and you should be having your 6-monthly ultrasound and your tumor marker alpha fetoprotein. Again, if you're a B, if you're a B, you should also be surveilled. And if you're a C, where your liver is not functioning very well, but you are awaiting liver transplantation, you should also be having your ultrasound and tumor marker every 6 months. For patients with hepatitis B, if they have significant fibrosis or cirrhosis, they should also be surveilled. And also for hepatitis B without fibrosis or cirrhosis who have a family history of HCC. Patients with hepatitis B and D co-infection. And then for hepatitis C, again, if you have advanced fibrosis. And also for patients with hemochromatosis, with advanced fibrosis. And importantly, patients with other liver diseases where the individual has a high risk of HCC. So individual consultants can use their own discretion and local policy to put people onto surveillance programs as well. Sorry, just in my window. So what is really good about this is we now have like a minimum sort of expectation of what is required to establish who should be on a surveillance program in the UK. People might wonder why we don't have a formal surveillance program in the UK like breast or colorectal cancer have. But actually, the volume of cirrhotic patients is so great that organisation and funding of such a program would be absolutely very, very challenging. So what has happened is these guidelines have now been published as a guide to each trust of what is required as a minimum, and they need to put in place a system that will work for them in that individual trust. So it will guide hepatologists, liver transplant surgeons, gastroenterologists, radiologists. It will guide all of them in terms of who needs to be on this program. In terms of treatment, very, very, very importantly, I need to point out that the majority of patients with HCC have actually got 2 potentially life-threatening diseases. It's not just the liver cancer, it's the cirrhosis. And any management must address the challenges of the underlying liver dysfunction and the cancer. It is not correct to just treat one. Both have to be treated because each one of them pose a threat to your life. Management actually requires very close working between hepatology, oncology, liver surgeons, gastroenterologists, because they all have a part to play jointly in managing this disease. again, just re-highlighting the fact that the cirrhosis complicates all aspects of the cancer management, okay? Your prognosis is not just influenced by the extent of the tumor, but also by the severity of your liver disease, your cirrhosis. We have lots of patients who don't understand why they can't have treatment for small liver tumors if their liver is not functioning very well. And it's always very hard to help people to understand that actually small HCC may not pose a big threat to your life, and it might be best to just leave that for a little while whilst your cirrhosis stabilizes, or your liver recompensates and your liver function improves a little bit, because doing treatment to your HCC at that time could make your liver struggle even more, which could be very serious. So that's something that is very difficult for everyone to get their heads around. Local regional therapies such as embolization treatment or heat treatment, like radiofrequency ablation, or transarterial chemoembolization. Yes, they are good treatments that are very well tolerated, but they can also damage the background liver. So you have to be very careful to monitor the effect of these treatments on the background liver. In terms of how we stage liver cancer, so the Barcelona Cancer Liver Clinic algorithm has been around for, I think, 25 years now. And this is an algorithm and strategy for prognosis, prediction, and treatment recommendation. And it's really great to see this algorithm look so busy, actually, because when I think back to 10 years ago, when I was starting to look after more and more HCC patients, this algorithm was about half the size, actually. And what that tells you is that actually there are more and more treatments that are coming through. So this algorithm takes into consideration not just the size of your tumor, the extent of your tumor. It considers your liver function, your Child-Pugh score, your performance status, because we know that these are all things that predict your outcome from treatments when you have liver cancer. And for example, if you had a very early stage liver cancer, less than 3 centimeters, you would be offered potentially ablation therapy, or maybe a resection. And if this didn't work, or you had a recurrence, you would then be able to go on and have embolization. So this is a very useful algorithm in guiding teams with treatment with different lines of treatment. If you summarize that slide in terms of treatment, this looks a little bit easier, but I've tried to pull out concisely the categories of treatment that are currently available to HSE patients. So in this section here, you've got the kind of more curative treatment. So you've got the transplant, living donor transplant, resections. Then you've got kind of more intermediate stage treatments like the heat treatment, the embolizations, and these two here are the internal radiation and external radiation treatments for liver cancer. They can be used to get you to transplant, to downstage you to resection, and they can be very good at getting you back into this category, or indeed just holding your disease until you get a liver transplant. And then if you head over to this category here, this is quite an impressive long list of all the new drugs that have become available for liver cancer over the last probably 10 years, actually. It's hard to imagine a time, but it did happen where we didn't have all of these drugs for patients, actually. So for me, it's quite nice to see that it's an active area of research. There's lots of clinical trials ongoing. We now are using targeted therapies, immunotherapies to treat liver cancer. So this is all very encouraging. In terms of finding support, so Liver Cancer UK is part of the British Liver Trust, and this website has a lot of information for patients diagnosed with HCC. Our main role at Liver Cancer UK is to provide information and support to new HCC patients, or patients who are on treatment. And we're a team of 6 specialist liver nurses and we have a lot of support groups, and there's also the online liver health community. And our nurse-led helpline is open Monday to Friday, 9 to 3, and the opening hours are actually extending next week from 9 to 4. I wanted to mention our support groups actually, because they offer so much information for patients, and we have such a big variety of them running. So I will go through them actually. So we have a liver cancer support group, we have alcohol-related liver disease, hepatic encephalopathy, we have the genetic and autoimmune daytime and evening time, we have the carers group, the drop-ins, the MASLD that we talked about earlier, hepatitis B, and the UK pre and post transplant, and the under 40s group. And all of them are facilitated and managed by the British Liver Trust, and they offer peer-to-peer support for patients, their carers and family, and anyone affected by liver disease and liver cancer. And the aim of these groups is to share as much information as possible on how to look after your liver through topics such as diet, exercise, and managing liver conditions, as well as encouraging support. We're often joined by guest speakers who offer their area of expertise to support liver patients and their families as well. I just wanted to mention that the Liver Cancer UK website is now available in over 100 different languages, and it's been tested with bilingual healthcare professionals and supporters. And this service is also now available for the main British Liver Trust website as well. In terms of physical activity and exercise, this is a really difficult one. The really important thing to say when you talk about exercise and diet in the context of liver disease, it is not one size fits all. You've got to be very, very clear when you speak to a patient what kind of liver disease they have, as to whether it's fatty liver or whether it's advanced liver cirrhosis. The advice is completely different, and one size absolutely does not fit all, okay? Generally speaking, the NHS recommends that we do at least 2.5 hours of exercise every week. So about a half an hour a day, 5 times a week. And then there's just 2 days where you do some strengthening exercise. I always say to callers, don't worry if that's too much for you. Just make a start, even if it's a 5-minute walk or a 10-minute walk. Just make a start and build up. Okay. You know, patients with advanced cirrhosis, you know, have very, very low levels of energy, so it's not going to be possible to do a half an hour. But even just a 5-minute walk around the garden is somewhere where you can start. Build up slowly over time, and if it's difficult for you to stand, you can do some seated exercises. It all counts as strengthening exercises and helps preserve your muscles. And also don't forget that things like mowing the lawn, riding a bike, and just even brisk walking to the shop to get milk and bread, this all counts as exercise. It's important to say that keeping yourself fit does help you to tolerate treatments for your liver cancer much better. We know that patients who are fitter prior to treatment end up recovering quicker and being discharged more quickly from hospital. So this is very, very important in terms of tolerability of treatment. In terms of diet, it's the same criteria again. Not one size fits all. If your liver is healthy, then obviously a well-balanced diet can reduce your risk of developing fatty liver, for example. If you have liver disease, eating a good balanced diet is essential to maintain strength and a healthy weight. But you may also need to change the food you eat depending on the type of liver disease you have. The stage of the damage to your liver, for example, cirrhosis, those patients have very special dietary needs. For example, they should have a snack just before they go to bed at night because they don't store glycogen very, very well. And if you have any eating difficulties, if you have quite a big liver tumor and you've got nausea and you've got lack of appetite, then obviously the criteria or the guidance for that is very, very different. So the point here is the advice has to be very individualized based on your liver disease and the cause of your liver disease. And I would urge you to not make any big decisions about your diet without getting some advice from your liver nurse specialist, or ideally, if you have cirrhosis, from a dedicated liver dietitian. And just lastly, a little bit about my role at the British Liver Trust. So this is actually a new partnership between Macmillan and the British Liver Trust to support patients with liver cancer. Both charities recognise that this is a dual pathology disease. We're dealing with liver cirrhosis, you're dealing with liver cancer, and actually bringing all the expertise together to jointly manage these patients from two charities is the best way to manage HCC patients. My role is funded by Macmillan, but I'm actually employed by the British Liver Trust. And my main responsibilities in this Macmillan Liver Cancer role is to work as part of the specialist nursing team at the British Liver Trust to support patients living with liver cancer and empower them to live well, and also just ensuring patients living with cancer know all the full range of resources and services available from the British Liver Trust and Macmillan, and also navigating and coordinating where necessary. And I do this Monday to Friday on the nurse-led helpline. And I think that's me, Becky.
Brilliant. Thank you so much, Pam. I hope everybody found that as interesting and informative as I did. Thank you very much. So now I would like to hand over to Frank. So Frank is going to share with us his incredible experience that he had. It's really, really inspiring. And it started when he visited his GP earlier this year. Thank you, Frank.
Hi everyone, my name's Frank, and I've been on quite a journey with my health over the last year, which I'm delighted to share with you all today to highlight the importance of keeping a close eye on your health and the positive outcome of early diagnosis. After retiring at 66 in June of 23, I spent a busy summer caring for my grandchildren, as we all do. And however, during that period and after that, I soon developed a serious chest infection, which took months and months to recover from fully. In early 24, I decided to visit my GP for what I would like to call a health home MOT, to ensure that everything was okay. But during my visit, I had several tests which were conducted, including checks for blood pressure, blood tests, and cholesterol. To my surprise, these tests revealed elevated liver markers. I also learned that I was pre-diabetic with a blood sugar score of 42 and had high blood pressure. This led to prompt referral for a fibroscan, which is a non-invasive liver scan. It was conveniently performed in a white NHS mobile unit parked outside my GP surgery as part of a community service. My fibroscan score came back immediately at 11.9 kPa, significantly higher than normal. This indicated possible fibrotic or cirrhotic damage, which alarmed me considerably, especially as someone who had always been active throughout my 24 years of military service. While waiting for further investigations, I immediately began to make lifestyle changes, incorporating more walking and swimming to my routine. My doctor provided guidance on maintaining a healthy liver by cutting out alcohol, eating healthier, and staying active. I also started researching liver health, assessing information on the British Liver Trust website, and gathering resources about my condition. In April, I underwent further tests, including an ultrasound on the 3rd, followed by a CT thorax, chest, and MRI scans on the 12th. In early May, I received the CT results, which revealed that I had a fibrotic fatty liver and a 1.4 centimeter lesion on my liver. There was concern it could be malignant, so I was scheduled for what is called a PET scan to determine whether the lesion would light up on the PET scan, indicating potential cancer. Although the lesion nature was still uncertain, it appeared to be confined to my liver. As a precaution, I was scheduled for a microwave ablation, a procedure to remove the lesion. I had the procedure in early July, which was meant to be a day procedure, turned into an overnight stay due to the unexpected pain and discomfort, which is quite rare for this type of procedure. I recall the senior liver nurse telling her colleagues, "We need to keep Frank in overnight." And the nurses in the liver unit took exceptional care of me, closely monitoring me and my blood pressure and ensuring that I was comfy all night. A few weeks later, I had another CT scan. So by early August, I learned that the operation had been successful. However, the scan also revealed a new, smaller lesion, about 7 millimeters in size. The doctors weren't overly concerned, but I was scheduled for an ongoing monitoring, including a follow-up fibroscan at the Derriford Hospital. The results of the fibroscan showed significant improvement. My liver readings dropped from 11.9 kPa to 6.5 kPa, and my CAP score, which measures liver fat, decreased from 323 to 266. The technician performing the scan reassured me by saying, "You would never, ever have known you had a liver problem." It was a great relief for me to hear that. Throughout this 8-month journey, I've learned more about managing my health. Nutrition advice led me to start intermittent fasting and adopt a healthier diet. By April, my initial scans, my blood sugar levels dropped, my cholesterol's improved, and I'm embracing this lifestyle changes. I feel incredibly fortunate to have received such informative and supportive care. The Southwest Liver Unit has been exceptional, providing me with detailed information through phone calls and letters, while the British Liver Trust website has served me with a fantastic resource. I also received excellent post-care after my surgery, which was crucial for my recovery. I am seriously grateful for the incredible support from my healthcare team and the NHS Liver Programme. I'm optimistic about the future. The experience has taught me that with the right care and lifestyle changes, we can all take steps to stay healthy. Now, as I look ahead, I'm excited to enjoy my retirement to the fullest. And thank you very much for listening to my story. Thank you, everyone.
Oh, thank you so much, Frank. I guess that's a really difficult journey for you to have been on, but it's wonderful for you to be able to talk to us about it, and we're very, very grateful. So thank you so much. We're going to have a look at some of the questions that have come in. So Pam's actually answered some of them already, but just in case people are not confident with their IT skills, I'll just read what's been said about those ones and then read out the other questions that Pam's going to answer. And we have had a couple emailed across as well. So in terms of the two that were briefly answered, so if you want to join a support group, how do I do it? The easiest way to do that would be just to type in to Google, probably, British Liver Trust support groups. It will take you to the support group page, and there'll be an option there for online groups, which you then click. Once you've done that, you can then register. So you'll fill in your details, and they will be then stored in our system. So you will then get an automatic invitation to the next support group or support groups that you've registered for. So you can join as many as you want that are relevant to you. So, for example, I run the pre and post transplant group, but we have attendees in that, obviously, with liver cancer. And then you have people, for example, in the liver cancer group who are also in the HE group. So it's not, about one group for one particular, it's not a one size fits all. You can be in as many as you want. So the next question was, are symptoms of HCC different from those of cirrhosis? And Pam has kindly written, some symptoms are the same, such as fatigue, but others, such as bloating and pain, are not. Pam, I didn't know if you wanted to just add anything or caveat that.
Yeah, it's quite difficult because it really does depend on the size of the tumor and sometimes the position. You can have a very, very small tumor that doesn't cause any symptoms. It's not pressing on any nerves, causing any pain. It's not causing any jaundice, and you don't have any symptoms. But if it gets bigger, obviously you start to feel a bit more distended and a bit more bloated. You get a bit more pain and you feel a bit fuller quicker after eating because you've got something that's potentially pressing against your tummy. So there is overlap. And I would say if you have cirrhosis anyway, you depending on the where you are in the eligibility criteria for surveillance, it's easier if you're on the surveillance program because you'll be having an ultrasound every 6 months. So if you're confused about your symptoms and you're not sure if things are changing or it's the way you've always felt since being diagnosed with cirrhosis, if you're on a surveillance program, you'll obviously be able to get reassurance from that, or if there is something, it will be picked up quite early on as well.
Thank you, Pam. So got a couple of questions for Frank that have come in. Firstly, you've had a positive comment there. It's not a question, Frank, just one of the listeners saying, great attitude, Frank, thanks for sharing, which obviously is lovely.
Thank you.
So the first one for Frank is, what an inspiring story. Thank you for sharing. And did you find it hard to change your lifestyle, Frank?
After retiring, I was previous to retiring, I spent a time in a very physical job. And then when I retired, everything stopped except for my physical. I do a lot of walking, I do a lot of swimming, but it was mainly my diet that I had to change, being a chocoholic, as they say. So I had to change something, and I researched what I could do from information from the various sites, especially the British Liver Trust. And it was really difficult at first to change my diet, but as I got used to it, I was feeling better, so it made me do it even more. Excuse me. So it was hard at first, but now it's just a routine.
Amazing. Thank you, Frank. Did you want to add anything to that, Pam, at all in terms of top tips or?
Yeah, I was going to say, if you were diagnosed with MASLD and you know an early HCC like Frank was, it's quite motivating in some respects because you know that even if you have your HCC treated with a radiofrequency ablation, you still need to make changes, because if your liver carries on being fatty and becoming scarred, it's a fertile ground to grow new tumors. So it's not as simple as saying, oh, well, that's sorted now, I'll walk away. That's the cancer sorted, but actually the background liver is not sorted, and you could potentially go on to get more advanced scarring and new tumors pop up. We know that there's an increased risk for patients with MASLD of recurrent tumors if they don't make the lifestyle changes.
Yeah, can I just add something there, Becky?
Of course, yeah, by all means, Frank.
I mean, the lifestyle changes, as Pam has just said, mine was a big change because I was eating the wrong stuff and I changed to the right stuff and kept my physical going with it. So not only eating well, but exercising well, as Pam said earlier on in a speech about walking. I walk 30 minutes with my wife a day. We go and swim 50 lengths 3 times a week in the swimming pool and maintain a healthy diet by intermittent fasting. So not only do you have to control that diet, but you have to keep the body physically fit so everything stays good.
Yeah, Yeah.
Lovely, thank you. So another question for Frank. So Frank, how did your family feel when you were diagnosed? And the second part to that question is, do you feel like your life is back to normal now?
Well, first of all, it was a massive shock to my family, my good lady, and my two sons, and I have 6 grandchildren. And yes, they were all worried. They were all worried that Grandad was ill, and he's never been ill in his life before. So it was a big shock to them. But the support that they gave me was fantastic, and they all rallied in, and they knew that Grandad had to change some things, and they also supported me in a way. I have some very supportive grandchildren who
no more ice creams,
no more. Yeah, my wife just said no more ice creams, no more chocolate.
Not an Easter egg.
And my first year, I've not had an Easter egg, which is it was amazing. But it all changed. The support was great, and yes, the family did get a shock, but it's all working out well now, which I'm really pleased.
Amazing. Thank you, Frank. So we've got some questions for Pam. So the first one is, please could Pam run through some of the main treatment options for HCC, as I'm finding it all very overwhelming.
Okay. So if you're lucky enough, like Frank, to present very early and you have a small tumor, sometimes it's not always about size. It might just be that you've got a bigger tumor, but it's on one lobe of the liver, and the surgeon feels he can resect part of the liver. You can go on and have curative resections. So surgery has progressed a lot nowadays. The liver used to be quite a difficult organ to operate on because it's very vascular and there's a risk of bleeding. And then there's always a risk of liver failure after the resection because you're relying on the remnant liver, the bit that's left, which of course is mostly cirrhotic, to regenerate. And it can be slower to regenerate when it's cirrhotic. So historically, it was always considered quite risky, but they now have better ways of assessing that and looking at how high the risk would be of bleeding or not regenerating. They have special tests called wedge pressure tests, ICG clearance tests, that help pick the better patients for surgery. So they'll always think about surgery if they can. That's always the first question at the multidisciplinary team meeting. Can we chop this out? That's always the first question. And if for any reason you can't, if it's too extensive or it's on both lobes or it's not going to be possible because the risk of bleeding is too high, etc., they would then think about liver transplantation. And of course, there is criteria that you have to meet in terms of size and number of lesions. But there is also now the extended liver transplant criteria program in the UK where you can be out of criteria, but you can be successfully downstaged with something called embolization. And if your disease behaves itself and 6 months later you're still downstage, you could potentially be listed later on. So you always initially think, can we cure this? Can we chop it out? Can we transplant that patient? And one of the other options that is considered curative is the radiofrequency ablation therapy, which essentially is a minimally invasive procedure. It's not open surgery. It's a day case procedure. Some patients stay overnight like Frank. But that's basically just burning the tumor. We know that the tumor dies around 60 degrees and the probe is heated up to 90 degrees. So that's sort of thinking about curative options. If those options are not possible, then it's a lot of patients go on to have embolization, which again can be a day case procedure or you stay overnight. And it's a catheter into the femoral artery into the hepatic artery, which feeds the liver tumors. And then you block off the blood vessels to the tumor with little particles. And that tends to be a very well tolerated and a treatment that's carried out a lot. It's been around for about 30 years. and we see some very good results with that. And also it's a way to keep transplant patients on the transplant list while they're waiting for a liver, because they have to stay within the criteria when they're waiting as well. If your cancer has progressed, which quite often is into the portal vein in the liver, those options, embolization and surgery and transplant, are normally excluded. So then it would be on to that nice long list of systemic therapy options that we talked about earlier. And those drugs, just generally speaking, stop the liver tumor producing something called vascular endothelial growth factor, which is a protein that helps the tumor to grow itself a new blood supply and survive. So you have some targeted therapies such as lenvatinib or regorafenib. You were also potentially offered immunotherapy, which takes the brakes off your immune system and helps it to recognize cancer and to fight cancer. So that's just sort of generally sort of thinking about all options for liver cancer. Becky, I noticed there is another question in the chat. Did you want me to read that one out, or?
Well, I think if we go on to the one about managing cirrhosis, maybe.
Oh, okay, sorry. Okay, fine.
I know you did talk about cirrhosis in detail, but again, I think probably it's quite overwhelming, isn't it? There's a lot of information.
Yeah. And actually that might answer some of the other questions coming through, actually. There's a bit of overlap. Okay.
Yeah, thank you, Pam.
Okay. So in terms of cirrhosis, it's really, really difficult, because there's not anything you can do specifically when the liver is decompensating and struggling to function. You need to have good support from your hepatologist or your gastroenterologist or your GP. And it's about kind of managing the key symptoms of decompensation, which can be the fluid in the tummy. So making sure that you're taking your water pills, such as spirolactone or furosemide, which the team would have prescribed you, and having your regular blood tests to monitor your kidneys to make sure they're not getting too dry. And the GP often plays quite a helpful role in monitoring those bloods in between going to your hepatology clinic. Sometimes just keeping an eye on your weight and knowing if it's going up or coming down can be quite helpful when you go back to the hepatology clinic, so that they can increase or decrease your water medication if necessary. In terms of encephalopathy, really, really, really important to make sure that you're opening your bowels every day and clearing those toxins. Other patients will have rifaximin prescribed, and just making sure you're taking that. But also just for carers and family members, just early detection. If they notice that, their loved one is becoming a little bit more sluggish or slow or confused, it's just making contact with your liver team or your GP and getting them reviewed before it gets quite severe. So often it takes time for the liver to recompensate, and it doesn't always. It's very uncertain. There will be periods where it functions well and it's compensated, but there will be periods where it's not functioning well and it's decompensated. But that can be very, very, very difficult for liver cancer patients, because often you're not having treatment for your liver cancer because your liver dysfunction is too bad. And people, I think, sometimes think, oh, it might get better in a week or two. It can take many, many, many weeks, and sometimes it doesn't get better. And it's a lot of uncertainty to be dealing with. But in that period, it's just making sure that you're in contact with your hepatology or liver nurse specialist, your GP. Some patients with advanced cirrhosis also get really, really good support from community palliative care teams who can support a lot as well. So I would say they're sort of the sort of top key things I would mention at the moment.
Lovely, thank you, Pam. We have had some questions that were emailed in. So one of those was, what is the follow-up after treatment and what tests and scans should I expect?
And is that's for HCC,
It
Nikki?
is,
Yes.
yeah.
Yeah, so normally you would have scans every 3 months for a couple of years, and then go back onto your surveillance program of 6 monthly scans. So it normally is 3 monthly for 2 to 3 years, but it's dependent on the extent of your disease and the treatment and your histology and your oncologist or hepatologist will clarify that, but it's normally 3 monthly for a couple of years and then reverting back onto your normal surveillance. And you would have, after your liver cancer is treated, you would have CT scan of your liver or an MRI of your liver, and you would have your alpha fetoprotein checked as well. Because you've treated the liver cancer, but you've always got to remain vigilant. Whilst you have a cirrhotic liver, fibrotic liver, or even a fatty liver, even though that's rarer, there is a risk of growing more tumour. So you've always got to be ensuring that you're on time with your surveillance, and if it's not happening, that you're chasing it and getting the dates booked for bloods and scans.
Brilliant, thank you. And another question is, so this person's basically saying they're struggling with their mental health since their diagnosis and feeling overwhelmed with that, and any suggestions around, you know, where they can reach out to and what they can maybe do for that.
Okay, so I appreciate that the liver nurse specialists have quite big workloads post-COVID, but the first place you should always start is with your clinical nurse specialist or your liver team. Nurse specialists are normally able to provide support, and sometimes by getting more information or having more advice can actually help your mental health. I often find that giving patients more information really helps to alleviate anxiety or to reassure them as much as one can. And if that's not enough, it's asking your nurse specialist at the hospital what services are available in terms of being able to see a counsellor or a psychologist. I would also really strongly suggest the support groups, the HCC support group, the British Liver Trust run, Liver Cancer UK. I think there's a lot of support to be had on there. Equally, I am in this role at the British Liver Trust. They can also contact our nurse-led helpline. We're here every day, Monday to Friday, and we're very, very happy to try and offer some support and chat through some of your concerns and see if that helps your mental health.
Thank you, Pam. And I think just echoing that again about the support group. So it is peer support, and people feedback to us that they benefit a lot from just having other people in a similar or the same situation as them. And it's a completely confidential forum. You don't have to speak. Sometimes people just like to listen. And there is no obligation to come to every single one. We sometimes see people drop in for a few and then they take a break. It is very, very flexible. So it's really about making it work for you. So another question that came in via email was, if someone has been diagnosed with HCC, does that mean that their family members are more likely to get HCC as well?
It depends on the cause of the liver cancer. So if it's hepatitis B, I mentioned earlier, if you have a family history of HCC in the context of hepatitis B, then actually you should be on surveillance. But equally, if there's a history of high blood pressure, high cholesterol, diabetes and a BMI in the family, then there may be an increased risk to you of having MASLD. So you could use our risk checker that we've talked about earlier on. And if it identifies that you have got a risk factor, then I would go and see your GP and discuss what might be the best way forward for you. Because if it is something like you having the family history of the high BMI, the high BP, the cholesterol and diabetes, it would be really important that the GP checks your bloods and treats accordingly, and you make the lifestyle changes if you are at risk.
Lovely, thank you, Pam. And I just wanted to add, as I was looking back on the questions, particularly the one about mental health, I think it's important just to note there that family, very close friends, carers, they are also encompassed within that about reaching out and looking after their mental health. So if anyone's listening on behalf of a loved one, there is our carers support group as well, and that is for carers of anyone with any sort of liver disease, and it's a really nice space for carers to be able to get maybe that time where they can focus on their own mental health and discuss strategies and ways to cope and things like that. Pam, I just want to say thank you so much for answering those questions. If you had to, in a nutshell, maybe just summarize like a takeaway for people from today, like a little conclusion, perhaps, what would you say? You've done some amazing like technical info for everybody. So what are the like real takeaways for people?
Yeah, so I think it all starts with the cause of your liver disease. So that's got to be the top priority. So if you have fatty liver from a high BMI or from other metabolic factors such as the blood pressure, the cholesterol and diabetes, that you are proactive in managing that. If your liver tests are abnormal or you are concerned, your GP can calculate your risk of developing any sort of scarring. There are ways to do that. And they can send you off for a fibre scan to look at whether you have any liver stiffness and to look at the composition on your liver. So if you have any sort of concerns about those metabolic factors, it's going to your GP. Yes, I know it's hard to get appointments, but it's getting it booked up in advance and going along and addressing those issues. Anybody who is told that they have a fatty liver on an ultrasound that was done for another reason and the fatty liver was picked up as an incidental finding, do not ignore this. Go and ask your GP more questions and say, do I need more tests? How bad is it? Is it quite severe? Is it moderate? What do I need to do? If you're struggling to lose weight, because it is really, really hard doing it alone sometimes, ask your GP, can I be referred to a weight loss program? Can I get a gym pass? What can I do? And how can I know that this is getting better? Follow up with it. Go back in a couple of months and say, I've lost X amount or I've not lost X amount. You've got to follow up on it. Prevention is so much better. So it's been really proactive. Equally, if it's hepatitis or you think there's a risk of hepatitis, go and get checked, have the treatment. All of these things will lower your risk of developing scarring and liver cancer. So be proactive is my main message. I've spent a very, very long time looking after patients who have presented with advanced liver cancer and who never knew that they had any scarring or cirrhosis or hepatitis or fatty liver. And we've been in clinics where we say, you've got cirrhosis, you've got hepatitis, you've got liver cancer, it's inoperable liver cancer, and they're pretty awful, irreversible situations to be in. So get in early. If you have any concerns about risk factors for fatty liver or liver disease, just be proactive. And if you do end up getting a diagnosis of cirrhosis, it's making sure that you are on time with your 6-monthly ultrasounds and your alpha fetoprotein, so that when it is detected, all the curative options are on the table as options for you, because they give you the best outcomes. So I think that's my sort of biggest takeaway message, actually.
Amazing. Thank you so much, Pam. And just a few things really in general from us here at the British Liver Trust. So we've got, obviously we mentioned our support groups. We also have the nurses helpline, which Pam mentioned already, which is moving to extended hours from next week. So that'll be 9 to 4, Monday to Friday, excluding bank holidays. We also have on the livercanceruk.org website, for example, so much support material, like questions to ask your specialist, which you can find on there, questions to ask your GP. We would always suggest going particularly to your specialist appointments, well prepared, because it can be very difficult to remember everything on the spot. Please never feel silly if you're going in and making notes. Some of them you can even ask if you can voice record, and obviously as long as you give them notice, many of them won't mind if you record your appointments. So I'm just referring to my notes here to make sure I have covered everything. So yes, the liver cancer risk checker tool, we cannot overstate the importance of that. So there is a nice link to that now on the liver cancer website. You'll see it right there. And we do encourage you to explore that with your friends and family. So there is one last thing from me, which is that some hospitals will have a peer support offering. Not all hospitals will. Again, it's a little bit of a lottery, but that could be a question that you ask if there is a peer support or face-to-face support group, because all hospitals are different, and some will have provision for people, particularly with things like HCC, and those that are lucky enough to have centres where those are available find that to be really, really beneficial. If there's anything that we haven't covered that you would like more information about, you can either call the helpline and speak to our lovely nurses, or if it's just a case of a question that you want to jot down, if you email outreach@britishlivertrust.org.uk, then that will come through to me and the guys on my team, and we would love to help you in finding out an answer to that question. But that is all from us. So it just remains for me to say a huge thank you to Pam and a huge thank you to Frank. You've both been amazing. So thank you so much, and we hope to catch you soon at another webinar. Thanks everyone.